Hello everyone and welcome to our module on other amino acids. In another module I talked about the amino acids phenylalanine and tyrosine, and in this module I'm going to talk about some other amino acids. In general, there is a lot of amino acid biochemistry and most of it is not relevant to step one. The amino acids I'll review in this module are either used to synthesize important molecules or they're involved in a specific disease process. We'll start with the amino acid tryptophan. This is the structure of tryptophan on the screen here. It has a large, bulky side chain with two rings, and tryptophan can be used to synthesize the neurotransmitter serotonin, which is also called 5-hydroxytryptamine or 5-HT. Serotonin got its name because it was initially thought to be a vasoconstrictor, and hence it could increase the tone in the serum. The first step in metabolism of tryptophan is conversion to 5-hydroxytryptophan. The enzyme that catalyzes this step is called tryptophan hydroxylase. And just like phenylalanine hydroxylase and tyrosine hydroxylase, tryptophan hydroxylase requires the cofactor tetrahydrobiopterin or BH4. BH4 is converted to BH2 in this step, and it must be regenerated by the enzyme dihydropteridine reductase, and this involves a molecule of NADH. An important clinical tie-in of tryptophan metabolism is the carcinoid syndrome. This is caused by GI tumors that secrete serotonin, and these tumors display altered tryptophan metabolism. Normally, only about 1% or so of tryptophan inside of cells is converted to serotonin. In carcinoid tumors, up to 70% of the tryptophan can be converted to serotonin. And in fact, tryptophan deficiency has been reported among patients who have the carcinoid syndrome. The symptoms of tryptophan deficiency are similar to the symptoms of niacin deficiency. They look like pellagra, and we'll talk about what that is in a few slides. The effects of the high levels of serotonin that are seen in the carcinoid syndrome include diarrhea, and that's because serotonin can stimulate GI motility. There is also increased growth of fibroblasts and fibrogenesis, and this leads to valvular lesions, particularly on the tricuspid and pulmonic valves. Patients with carcinoid syndrome often have stenosis or regurgitation lesions. And then finally, patients with serotonin syndrome often have flushing of the skin. This was once thought to be mediated by serotonin. It turns out there are probably other mediators like histamine involved. But be that as it may, diarrhea and flushing are classic symptoms of the carcinoid syndrome, and all of this is mediated by abnormal metabolism of tryptophan. Serotonin, which is synthesized from tryptophan, can be metabolized by the enzyme monoamine oxidase, and this is the same enzyme involved in the metabolism of dopamine and epinephrine and norepinephrine, which I discussed in the module on phenylalanine. This is the structure of serotonin on the left side of the screen here. Monoamine oxidase can remove this NH2 group. From there, the molecule of 5-hydroxyindole acetaldehyde can be converted into a molecule called 5-hydroxyindole acetic acid or 5-HAIAA, and this is the final metabolite of serotonin breakdown. It can be excreted in the urine. MAO inhibitors are sometimes used in depression, and that's because they blunt the breakdown of serotonin and boost serotonin levels in patients who are depressed. In addition, urinary levels of 5-HIAA are sometimes measured to diagnose the carcinoid syndrome, and that should make sense to you now because, as we've discussed, carcinoid patients have increased levels of serotonin coming from tumors, and therefore they have increased levels of 5-HIAA in their urine. Once tryptophan's been converted to serotonin, serotonin can be metabolized to melatonin. You may know that melatonin is secreted by the pineal gland in the brain, and it's used to regulate our sleep-wake cycle and our circadian rhythms. Tryptophan can also be used to synthesize the vitamin niacin, and you may know that niacin is necessary to synthesize NADH and NADPH. The conversion of tryptophan into niacin requires vitamin B6, and I talk about vitamin B6 in another module, but some of the symptoms of vitamin B6 deficiency are related to defective conversion of tryptophan into niacin. In other words, you can have symptoms of a niacin deficiency from being deficient in vitamin B6. There is a rare disorder called Hartnup disease where patients are born with absence of an amino acid transporter in the proximal tubules of the kidneys. This is an autosomal recessive disorder, and people who have this lose tryptophan in the urine. Often this is asymptomatic, but when symptoms do develop, the symptoms are from niacin deficiency, and that should make sense to you now because, as we just described, tryptophan is used to synthesize niacin inside the body. If people become symptomatic from Hartnup disease, they develop pellagra, and pellagra is the condition associated with niacin deficiency. They classically develop a hyperpigmented rash on exposed areas of the skin. If you look at this man who has pellagra on the skin here, you can see that he's got excessive pigment and darkening of the skin in the areas that weren't covered by his shirt. That's why he has darkening below the neck here and on his arms. Another symptom of pellagra is a red tongue. This is from glossitis, an inflammation of the tongue. Also, diarrhea and vomiting and central nervous system symptoms, including dementia and encephalopathy. People often remember the symptoms of pellagra as the three Ds: dermatitis, diarrhea, and dementia. The treatment for Hartnup disease is to eat a high protein diet, so you get lots of tryptophan that can be converted into niacin. In addition, you should consume enough niacin in your diet. Next, let's talk about the amino acid histidine. Histidine can be converted into histamine by the enzyme histidine decarboxylase. Histamine has many important roles in cells of the body, including an important role in the inflammatory response. Histidine decarboxylase removes this carboxylic acid group, hence the name decarboxylase. And just like many other decarboxylase enzymes, it requires vitamin B6 as a cofactor. Glycine is a very small amino acid. It's one of the simplest amino acids. This is its structure on the screen here, and it is very important for the synthesis of heme. Heme is composed of a large porphyrin ring. This is the structure of a porphyrin ring on the screen here, with iron in the middle. When you put iron in the middle, you now have heme. And even though it's a very big molecule, it's made up of lots of small molecules that come from glycine and also succinyl-CoA, which is part of the TCA cycle. And it's high yield for step one to remember that these two components are what make up the large molecules that you find in heme. The amino acid arginine has a number of important purposes. It can be used to create creatine, which is found in muscles, and it's a source of phosphate groups to generate ATP during exercise. Arginine is also a component of the urea cycle, and it can be metabolized into urea. We'll talk more about that in the module on ammonia handling. And then finally, the enzyme nitric oxide synthase uses arginine to synthesize molecules of nitric oxide, which is a very important vasodilator. Glutamate is an amino acid that also serves as an excitatory neurotransmitter. This is the structure of glutamate on the left side of the screen here. There is an enzyme present in the brain called glutamate decarboxylase, which can remove this carboxylic acid group here. And once that is removed, you now have a molecule of gamma aminobutyric acid, or GABA. GABA, in contrast to glutamate, is an inhibitory neurotransmitter. And so by manipulating the activity of this enzyme, brain cells can control how much excitatory neurotransmission versus inhibitory neurotransmission they will perform. And just like many other decarboxylase enzymes, glutamate decarboxylase requires the vitamin B6 as a cofactor. Now let's talk about the branched chain amino acids. These are three essential amino acids that are primarily metabolized by muscle cells, and all of them have a branch in their side chain. The three branched chain amino acids are valine, leucine, and isoleucine. Valine has a branch in its side chain, which I am circling here. There is also one in leucine, and finally you can find one in isoleucine. All three of these amino acids depend on an enzyme called alpha ketoacid dehydrogenase for their metabolism. This enzyme is often called BCKDC, which stands for branched chain alpha ketoacid dehydrogenase complex. And this enzyme is a complex just like the pyruvate dehydrogenase complex, which I talk about in a separate module. It has three subunits made up of multiple enzymes E1, E2, and E3. It requires the cofactors thiamine and lipoic acid, and all of this is the same as pyruvate dehydrogenase complex. All three branched chain amino acids go through a three-step metabolism. The first step is a transamination reaction, the second step is a decarboxylation, and the third step is a dehydrogenation. And the second step, the decarboxylation, is catalyzed by alpha ketoacid dehydrogenase for all three amino acids. The end products are different for each amino acid. Valine is metabolized into succinyl-CoA. Succinyl-CoA can enter the TCA cycle and become glucose, therefore valine is a glucogenic amino acid. Isoleucine is metabolized into succinyl-CoA, which can become glucose, and acetyl-CoA, which can only become a ketone body, therefore isoleucine is both glucogenic and ketogenic. And then finally, leucine is one of the two purely ketogenic amino acids. It is metabolized into acetyl-CoA and acetoacetate, and therefore it is a purely ketogenic amino acid. Children born with a deficiency of alpha ketoacid dehydrogenase have a condition known as maple syrup urine disease. This is an autosomal recessive condition. There are 5 clinical phenotypes in terms of how severe the disease is, but the classic maple syrup urine disease phenotype is most common. This is due to a deficiency of one of the major subunits E1, E2, or E3 of the alpha ketoacid dehydrogenase complex. Children with this disorder will have high levels of branched chain amino acids in their plasma and also high levels of alpha ketoacids. If we go back a slide, when you are deficient in alpha ketoacid dehydrogenase, you will have high levels of all 3 branched chain amino acids in your plasma. In addition, after this first step of transamination, all 3 branched chain amino acids are converted to structures called alpha ketoacids, and the level of these molecules will rise in the blood as well when alpha ketoacid dehydrogenase is deficient. And it turns out it is the alpha keto acid of isoleucine that gives urine a sweet smell, and that's how the disorder gets its name, maple syrup urine disease. The main problem in maple syrup urine disease is neurotoxicity, and this is primarily due to accumulation of the branched chain amino acid leucine. This is called leucinosis. Classic maple syrup urine disease will present in the first few days of life with lethargy and irritability, apnea and seizure, and possibly signs of cerebral edema. The diagnosis can be made by finding elevated levels in the plasma of branched chain amino acids. So in a board question, you want to look for elevated levels of valine or leucine or isoleucine to suggest this diagnosis. The treatment is dietary restriction of the three branched chain amino acids. So as I've shown you at the bottom of the screen, you want to eliminate valine, leucine, and isoleucine from the diet. People with this condition often have their plasma amino acid concentrations measured to make sure they're not eating too much of the branched chain amino acids. Thiamine supplementation is also often performed because this is a cofactor for the alpha keto acid dehydrogenase enzyme, and you want to try to maximize whatever of that enzyme is left functioning inside of cells. Now let's talk about the amino acid homocysteine. Homocysteine is a non-standard amino acid. This means it is not coded for by our genome. However, it is closely related to two standard amino acids, cysteine and methionine. Methionine is an essential amino acid, but cysteine is non-essential because it can be derived from methionine. If you look at the bottom of the screen here, you can see the chemical structure of these three amino acids, and you can see that they are very similar. This is the structure of methionine on the left side of the screen here. If you remove this methyl group, you will have the structure of homocysteine. And then if you take this sulfur group and homocysteine and move it one carbon closer to the carboxylic acid, you will have the structure of cysteine. And there is a metabolic pathway called the transsulfuration pathway by which methionine is converted to homocysteine and homocysteine into cysteine. And that's what we'll talk about in the next few slides of this module. Methionine can be combined with a molecule of ATP to form a very important intermediate called S-adenosylmethionine, or SAM. Basically, what you do is lop off the three phosphate groups here and attach the sulfur of methionine. This will form a molecule of SAM with this methyl group hanging out in space here ready to be plucked off. And that's the purpose that SAM serves. It's a methyl group donor for a number of reactions. It takes this methyl group attached to the sulfur and donates it to other structures. Once SAM donates that methyl group and the adenosine is removed, you are left with a molecule of homocysteine. As I showed you 2 slides ago, the only difference between methionine and homocysteine is removal of one methyl group. That's removed when SAM donates it, and thus you are left with homocysteine, and that means you have synthesized a new amino acid, homocysteine, from another amino acid, methionine. Homocysteine can then be combined with the amino acid serine using an enzyme called cystathione synthase that depends on vitamin B6. This will make a molecule of cystathione, which is essentially serine linked to homocysteine, and cystathione can then be metabolized into cysteine. Thus, you have synthesized from the amino acid homocysteine another amino acid, cysteine. As a byproduct of this pathway, you form a molecule called alpha ketobutyrate, and alpha ketobutyrate can go on to become succinyl-CoA and enter the TCA cycle and become glucose. And I show you this to remind you that homocysteine, and therefore methionine, which homocysteine comes from, can both form glucose via succinyl-CoA, and therefore they are both glucogenic amino acids. So I've summarized the transsulfuration pathway on the screen here. Methionine can be converted to SAM. SAM can become homocysteine. The enzyme cystathione synthase using vitamin B6 can synthesize cystathione, and cystathione can go on to become cysteine. What's confusing about the amino acid homocysteine is that it has an alternative fate. There is another pathway called the remethylation pathway. In this pathway, an enzyme called methionine synthase adds that methyl group back to homocysteine to regenerate methionine. This pathway involves folate, and it also involves the vitamin B12. Folate is converted to a molecule of N5-methyl tetrahydrofolate, and then this methyl group is given back to homocysteine to make a molecule of methionine, and as a result, you create a molecule of tetrahydrofolate, and this requires vitamin B12 as a cofactor. A normal homocysteine level is about 5 to 15 micromoles per liter, but many patients have mild to moderate elevations. These can be caused by vitamin deficiencies. If you're deficient in B12, folate, or B6, all of these vitamins are involved in the metabolism of homocysteine, and they can lead to elevated levels. In addition, however, some patients who have normal vitamin levels still have high homocysteine levels, and this has been found to be associated with increased risk of cardiovascular disease, specifically strokes and heart attacks. Unfortunately, clinical trials where patients were supplemented with folate to drive down the homocysteine levels did not lower risk. So it's not clear if the high homocysteine level is the cause of more cardiovascular disease or just a marker of higher risk for cardiovascular disease. When patients have a severe elevation of homocysteine, we call this severe hyperhomocystinemia. This is usually an elevation to greater than 100 micromoles per liter. This is often called homocystinuria because the homocysteine appears in the urine, and this is usually due to defects in one of the homocysteine metabolism enzymes. There are a number of autosomal recessive disorders which can lead to these very high elevations of homocysteine levels in the plasma. Patients who have very high elevations of homocysteine levels and homocystinuria have a common set of symptoms they display. The mechanism of these symptoms is unclear. The first one is dislocation of the lens of the eye. These people often have vision problems. They can have very long arms and legs, and they may have deformities of the chest wall. This is a picture of a patient with pectus excavatum. That's a characteristic deformity seen in high levels of homocysteine. Osteoporosis in childhood can occur, as well as mental retardation. And then the major problem with very high levels of homocysteine is blood clots. In addition to pulmonary embolism and DVT, these patients can have early atherosclerosis with stroke and MI, and they often die from a blood clot disorder or a stroke or a myocardial infarction. Now, these first two symptoms here, lens dislocation, long limbs, and chest deformities, can also be seen in Marfan syndrome, but don't get confused between Marfan syndrome and homocystinuria. Only homocystinuria will display these problems on the bottom of the screen. The classic cause of homocystinuria is a defect of the enzyme cystathione beta synthase, or CBS. If we go back a few slides, this is the enzyme that's deficient in classic homocystinuria. Thus, the levels of homocysteine get very, very high. You can treat this disorder by minimizing the amount of methionine in the diet, which will hopefully decrease the amount of homocysteine. In addition, you often supplement vitamin B6 to maximize whatever functional cystathione synthase is still present. And then finally, you need to supplement cysteine because it now becomes an essential amino acid when this enzyme is not working. And I've summarized these points on the screen here. The dietary treatment of homocystinuria is to avoid methionine, increase cysteine, which is now essential, and supplement vitamin B6. Some patients are so-called B6 responders. Now, classic homocystinuria is caused by cystathione beta synthase deficiency, but there are some less common causes. These include deficiency of the enzyme methionine synthase or defective metabolism of folate or B12. Specifically, there is an enzyme called methylene tetrahydrofolate reductase, and mutations of the gene that encode for that enzyme have been implicated in some cases of high homocysteine levels. If we go back to this slide again, some less common causes of high levels of homocysteine include deficiency of this enzyme here, and then methylene tetrahydrofolate reductase is involved in metabolizing folate into N5-methyl tetrahydrofolate. So if this enzyme is dysfunctional, you can also get high levels of homocysteine. I'll finish this module by mentioning a condition called cystinuria. Cysteine is a molecule composed of two cysteine amino acid molecules linked together. If you look at the bottom right side of the screen here, this is the chemical structure of cysteine, and the two sulfur groups are linked together. Cystinuria is an autosomal recessive disorder where there is poor reabsorption of cysteine by the proximal tubule of the nephron. And the main problem is recurrent kidney stones, and I talk about this in more detail in the renal modules on kidney stones. But for our purposes here in the biochemical modules, I want to mention that a methionine-free diet can be used to limit the kidney stones in patients who have cystinuria. A major problem that they have is recurrent kidney stones, and many of them will try to limit the amount of methionine in their diet, hoping to limit the formation of these cysteine molecules and therefore limit the amount of kidney stones. And that concludes our module on other amino acids.